Hi everyone. My name is Olivier Y Rouquette. I'm Senior Data Scientist at Swansea University Medical School. And today I'll present you with our team, the Population, Psychiatry, Suicide, and Informatics, and also share with you how we go from robust research to high impact. Our PPSI team is a thriving mental health research team led by Professor Anjon, and with over £40 million in joint funding over the last 5 years. And we apply what we call research, analytical, and programming expertise to answer mental health related questions. And this results in publication of research finding in high impact journals. But most importantly, and what we're probably the most proud of, is that we have a strong focus into translating research into policy and practice. Our leading expertise is in suicide prevention, self-harm behaviors, and mental health conditions, and it allows us to lead and collaborate on high-impact research initiatives, such as DataMine, which is a hub for mental health informatics research development. And DataMine works to ensure that mental health data meets the findable, accessible, interoperable, and reusable or FAIR principle. DataMine has also a very strong PPI group that is central to the role of the hub, and they've actually published with the PPI group and got their own funding. And they work with the industry to help bridge the gap between mental health data and the industry itself in a way that is acceptable for mental health patients. And with DataMine, we organize industry forum, but also capacity building and workshop and course to etc. We're also leading the population and patient e-cohort work packages of the Wolfson Center for Children and Young People Mental Health. The Wolfson Center was established in 2020 by the Wolfson Foundation to better understand adolescents' mental health. The main objective of this workstream, the workstream RELEAD, is to take advantage of the link data we have available at Swansea University to inform policy healthcare particularly around youth anxiety and depression. And for doing so, we're using both what we call classic epidemiology, but also machine learning and AI. And the work include works on childhood maltreatment that we'll see later, school absences and exclusion, but also the impact of deprivation. We're also leading the ADA Wales Mental Health Research Program. And for those, we focus on suicide, self-harm, and mental health prevention in line with the Welsh government's commitment to invest in mental health. And the Welsh government recognizes the importance of providing effective services, high quality and sustainable mental health services. And this research team seeks to provide evidence to inform, reform, and prioritize investment. And our work particularly focuses around 5 areas. One is school absences and exclusion of individuals with mental health diagnosis. We have prisoners and self-harm. Another work on the effectiveness of various mental health transformations, such as the NHS 111 Press 2, work on mental health of pupils educated in other than at school, or EOTAS, and more recently with the new census data, we'll be conducting research on the mental health of socioeconomics, ethnic minorities, and underserved groups. We're also leading on the ADP, or the Adolescent Mental Health Data Platform, that was funded by MQ. And the ADP platform was launched in 2018 and brings together routinely collected data from the SAIL data bank with cohort and survey data. And ADP provision research-ready data to make it easier and faster for researchers to deliver around youth mental health. And ADP is currently supporting, I guess, more than 30 projects, and research has gone to influence policy and practice. And one example is the guidance entitled Responding to Issues of Self-Harm and Thought of Suicide in Young People from the Welsh government. ADP also collaborates with charities such as Samaritans to provide evidence and recommendations for social media platforms to improve safety and policies around self-harm, for example. One example of a cross-cutting research of the team is this research on the external validation of coding for childhood maltreatment on using routinely collected primary and secondary care data. This study was conducted to address and improve the identification of childhood maltreatment using routinely collected healthcare data. And the purpose was to create a more reliable algorithm that can identify childhood maltreatment cases. And the idea was to aiding healthcare professionals in providing timely and appropriate intervention for at-risk children. This study showed that using better codes and combining various sources of data can help to identify childhood maltreatment cases more accurately. And this study led to the development of what we call a new phenotype to identify childhood maltreatment in primary and secondary care using ICD-10 codes and READ codes. And these phenotypes adds to the collection of validated code list and algorithm that we have developed within the PPSI team. And these codes allow us to efficiently and reliably extract specific conditions in primary and secondary care. All our phenotypes, code lists, and algorithms are openly available on the concept library, as such as in the HGR UK phenotype library. Another example of a cross-cutting research from our PPSI team is the work on the association between school absences and exclusion and recorded self-harm, neurodevelopmental disorders, and mental health conditions. And for this work, we link data from Education Wales, or EDU, with administrative, primary, and secondary care data in SAIL. And this research found that compared to peers with similar characteristics, such as age, sex, and deprivations, pupils with a recorded event of self-harm, neurodevelopmental disorder, or mental health conditions before the age of 24 years were more likely to miss school because of being excluded or due to absences. Or if we flip the findings, we could potentially say that records of exclusions or persistent absences are potential indicators of current or future poor mental health and could be used to target assessment or early identification of mental health difficulties. A third example is our work that uses the linkage between an external data set, or the SHRN data, which are the student health and well-being survey, with administrative primary and secondary care data in SAIL. And for this project, we were particularly interested in questions pertaining to in-person bullying and cyberbullying. And the results show that approximately 1/3 of pupils reported being bullied, with the most common form of bullying being in-person bullying at school, followed by in-person and cyberbullying. And we found that pupils who experience in-person bullying at school were twice as likely to self-harm as those who did not. And that's true even after controlling for other risk factors for self-harm. And this study emphasizes the impact of in-person school bullying such as other risk factors, such as being female or loneliness, on the risk of future self-harm in secondary school pupils. Now, let's focus a little bit more in depth in our latest research. And spoiler alert, or super proud moment, this paper will be soon, really soon in BG Psych. The paper is entitled Incidence of Self-Harm, Neurodevelopmental and Mental Health Condition Among University Students Compared to the General Population, and that's a nationwide electronic data linkage study in Wales. We know that, or we believe, or there are growing concerns that self-harm and mental health conditions are increasing among the students. And the question is it because of financial stressors, academic stressors, or could it be due to widening access to higher education? Actually, what we found during the research for this is that there are loads of selective, small sample questionnaire-based studies, but not many robust or population-based, and certainly not routinely collected research on the issue. So in order to assess the situation, we linked data from the Higher Education Statistics Agency, or HESA, between 2012 and 2018 with administrative and health record in SAIL. And we were able to include more than 95,000 first-time undergraduate students aged between 18 and 24 years of age, with more than 151,000 non-students with similar age and similar year of birth. And we run descriptive analysis, logistic, and Poisson regression. And the first question we wanted to answer was, what are the factors associated with becoming a student versus not becoming a student? And our results from the logistic regression here show that some individuals were less likely to become students. And this includes being male versus female, coming from a more deprived area with a strong association between with the deprivation gradients, and previous records of self-harm, neurodevelopmental disorders such as ASD, autism spectrum disorder, and ADHD, depression, schizophrenia, alcohol, and drugs misuse. So all these factors reduce the chance, or are associated, I would say more precisely, are associated with lower chances of becoming university students. The second questions that we asked pertain to the risk of dropout among university students only. And again, our results from a logistic regression show that some individuals, again, were more likely to drop out. And this include Welsh students or students registered in Wales and with a Welsh GP studying outside of Wales, male versus female, more at risk of dropout, individuals from more deprived area, again, with a strong association with the deprivation gradients, an older age at entry at university, and then various records of like self-harm and mental health conditions before or during the studies. And one example is that depression, either before or during studies, is associated with a higher risk of dropout, and on the other side with anxiety, which is associated with a higher risk of dropout if the record is before university, but not during university. So you can go through the paper if you want more detailed results here. The third question assesses how being a student versus not being a student was associated with mental health conditions during the studies. And the overall message or the overall results from our Poisson regression with a marginal mean post estimation show that students have lower incidence of self-harm, ASD or autism spectrum disorder, depression, anxiety, schizophrenia, and drugs misuse, but we had no differences between students and non-students for ADHD, eating disorder, bipolar disorder, and alcohol misuse. And if we look at the trends between 2012 and 2018, our results show that certain conditions particularly increased among students. And self-harm increased among students only during this period. In general, neurodevelopmental disorder increased among students, with ASD increasing among students, and ASD increasing more among students with time, or records of ASD, and records of ADHD increasing more among students only. Depression increasing in both groups, but increased more among students during this time period. Schizophrenia that decreased among non-students, but increased among students. And alcohol misuse that actually decreased among non-students and had a slight increase among students. Another way to look at the results is when we look at age at entry. And what we can say is that in general, students entering university at a later age are more at risk of all the studied conditions. One exception is alcohol misuse, for which younger individuals, both students and non-students, are more at risk. So if we roll back to the theme of the seminar, which is how can population scale data be used to evaluate and improve mental health services and people's lives, the results of our study clearly show that mental health conditions among university students is common, diverse, and wide-ranging. And our results show that students have different mental health needs and different mental health trajectories than non-students, and that their mental health conditions are associated with their academic journey in terms of accessing university, but also in terms of dropout. Regarding applied implication, campus-based well-being resources such as self-help are likely not sufficient to attend this diversity and variety of students' needs. And like the variety and this complexity of mental health needs from students requires what we call an integrated step care approach within university. And this should include like services from well-being and self-harm to counseling, up to supported referral pathway to mental health services when necessary. Limitations, like this study is a secondary analysis of routinely collected data that were not specifically collected for research. So for example, we had access to sex, but not gender. We had poorly recorded ethnicity within the HISA data. We actually decided not to use that. Potential misclassification bias, unmeasured confounding, or missing data. We were simply not able to assess when we had no data. The scale of the study allowed us to assess rare mental health conditions, such as bipolar disorder and schizophrenia, but the results should be interpreted carefully due to low numbers. Like other technical limitation, we did not account in this specific study of academic performance among students, and we use age at entry, not actual age for each event due to multicollinearity issue. That's it for me. Thank you very much.